So, as promised, welcome back. And again, we have seen a tremendous case, and now it's my pleasure to start session 5 and the second day of Rio, where the focus on this session will be the role of AF ablation and occlusion devices on stroke reduction. And I am delighted to again be joined by our panel of Jason Andrade and Rodney Horton. And of course, our presenter for this session will be in the middle. It will be Luigi Di Biase. So without any more delay, Luigi, I hand it over to you. The stage is yours.
Thank you very much, Julian, for the introduction. And I have to, yes. So the role of AF ablation and occlusion device on stroke reduction. I don't think I have the control yet. Yes, I do. So these are my disclosure. As you know, atrial fibrillation affects a lot of patients worldwide, US the most, but we have a problem with atrial fibrillation. That's why we have to talk about atrial fibrillation. And we know that many patients are affected by atrial fibrillation, as you can see from this slide, and many more will be in 2050. And this is why we have a lot of patient with atrial fibrillation, because it is connected to the age of the patient, and therefore we have many patients. But all we know is that atrial fibrillation increase the risk of stroke and all other comorbidity. So some problem. So atrial fibrillation, as you know, increase the risk of stroke, of dementia, of heart failure, and more importantly, the risk of stroke depends from the age of the patient. So we try to, do this in older patients, but everybody could be affected. Anyway, when going to look at the stroke reduction, I look at this paper in 2011, and from the DRG of the patient in the Intermountain state here, you can see that the risk of the patient may vary. And I'm still having some struggle with moving the slides. So, okay. From 37,000 patients that have atrial fibrillation, these patients were divided into 3 groups, as you will see from the following slides. And these patients were divided in patients without atrial fibrillation, no ablation, and atrial fibrillation and ablation. You can see that there were minor statistical difference, but the one that undergo ablation were probably sicker than the other. And this was not a randomized study, of course, as a limitation, but includes a big number of patients. You can see that the results of the mortality here show that patients with atrial fibrillation with ablation have a risk of dying similar to patients without atrial fibrillation, and this is statistical difference with patients that have atrial fibrillation that do not undergo an ablation. When I look at stroke risk, look at the risk. The patient without atrial fibrillation and patient with atrial fibrillation and ablation do almost the same and statistically different from patients that have atrial fibrillation that do not undergo an ablation. And from that paper also, you can see that no atrial fibrillation or atrial fibrillation treated with medication, you can see that there is a statistical difference. While no atrial fibrillation or atrial fibrillation and an ablation, the risk of Alzheimer's and dementia change dramatically when you undergo an ablation. There is another paper here from the Swedish people, very good in registries. We know this from the statins use and the forest trial. Here again, they went into the big database, and you will see now in the next slides. I'm sorry. They went into this big number of patients from 2006 to 2012. They get out the patient that were ablated and the one that were not ablated. They excluded the patient. They did a propensity score matching. And at the end, they compare basically 2,500 patients per group. And what are the data of this trial here? The data is that the stroke risk when patients undergo ablation versus no undergo ablation is statistically significant. And this includes patients from 2006 to 2012 with different operator, different techniques, but ablation still very important. Now, the results of their registry are also good for mortality, as shown in this other slide. Catheter ablation, no catheter ablation. So from non-randomized study, we have a lot of evidence. We did also a meta-analysis on AFib and the risk of dementia, and ablation clearly show benefit of not having of having less dementia when an ablation is performed when looking at the meta-analysis as published in the late 2012. Next slide. And you can see here higher dementia risk with AFib when without AFib. Next slide. So we also know now that early ablation better than late ablation. This is the East AFib trial. As you know, early intervention. This trial shows that you need to be in a sinus rhythm to be good. And next slide, please. You can see that relative risk reduction of 21% on the first primary outcome of death, cardiovascular cause, stroke, or hospitalization, or worsening heart failure when sinus rhythm is maintained. Next slide. What does it mean maintaining sinus rhythm? That when you compare maintaining sinus rhythm between medication and ablation, ablation always better. This is all trial. They all show ablation better. Next slide. And this is the AA4 study on circulation. Next slide. Show that the best way to maintain sinus rhythm, it's ablation over medication. Next slide. And the meta-analysis conducted very old in 2009, next slide, show that, of course, ablation better than medication. This is a meta-analysis on circulation arrhythmia. Next slide, please. So I'm gonna just, next slide, please. I'm gonna show you just a few slides that say, so early ablation. We know that with RF, early ablation, even without the failure of medication, is better to improve all the parameters. This is RAFT 1, next slide. RAFT 2, bigger trial, catheter ablations, early ablation without the failure of medication with radiofrequency energy. Next slide. And controversial Cabana here that showed that there was no major difference between catheter ablation and drug therapy. Next slide. But as you know, the trial, when you follow the intention to treat, show no major difference. Next slide. But when you look at the crossover, you can see that was about 27.5%. So patients that actually received an ablation but were not assigned to the ablation procedure. Next slide. Therefore, when you look at actually per protocol, you can see that there is a difference in the composite endpoint in the Cabana trial as well. Next slide. And this is actually the freedom from atrial fibrillation, which is the main thing to avoid and to have strokes. Next slide. The early ablation maintenance sinus rhythm has been also demonstrated by one of our chair, Dr. Andrade, with a different energy source, cryo, ablation versus antiarrhythmic drugs in this New England paper published last year. Next slide. And this is another paper, again, cryoablation, Dr. Wozni, early ablation versus drug therapy. Next slide. So I think that we know sinus rhythm better than atrial fibrillation, how to maintain sinus rhythm, early ablation, better than medication. When you do an ablation and you maintain sinus rhythm, all the trials have shown improvement in stroke, dementia, and other factors involving the brain. What happened with LA closure device? Next slide. I think we have many devices. These are percutaneous device. Next slide. We have the amulet. We have the Watchman. We have many more in Europe. We have surgical epicardial ablation, AtriClip, Lariat, many devices. Next slide. Each of them can be used with different anatomy, with different anticoagulation management, with different characteristic of each of the patients. Next slide. And all we know is that when compared to Coumadin, the device do well in preventing stroke. This is the Protect AF. Next slide. And when you look at all the trial, you can see that there is an improvement in ischemic stroke in all these trials. Next slide. One of the limitations is probably that when you do a sub-analysis, you have an improvement in hemorrhagic stroke when compared to ischemic stroke when looking at these patients, but this is our under and sub-analysis. Also considering we are comparing this with warfarin. Next slide. So I jump to the conclusion on the left atrial appendage closure presentation part that, okay, what happened in patient with a DRT? What happened in patient with a peri-device leak? What happened in patient compliance to medication? What happened on the long-term data on this device? I think that the device have proven to be non-inferior to warfarin. We have no big trial that have compared the closure device to NOAC. We have smaller trial, but not a big trial. What to do with leaks, what to do with DRT, how to deal with patient compliance. Many points for discussion here. For sure, LA closure device represent a valid alternative to long-term anticoagulation, and they should be considered. Thank you very much for your attention.
Yeah, thanks, Luigi, for this nice overview. I mean, it's a big task to put in all the data within such a short time. And let me start with one question. You as an expert in catheter ablation, for instance, why do you think we have not been able so far to reproduce the retrospective data in a prospective fashion? So is it operator, is patient selection, is it technology? And the other question, or your comment maybe, as a proof of, let's say, the concept at least for stroke prevention with a closure of the appendage, the Laos trial or Laos 3 trial did at least give us more data, and should we also follow on that path? And the last question or your thought would be, if you do consider both procedures, would you combine it, or would you do at a stage and in what, let's say, a sequence?
So number one, let's start from the last one. I think doing the same procedures right now, the major limitation is cost and reimbursement. Assuming that cost and reimbursement is not an issue, it depends. That sometimes I feel that the left apical appendage needs to be ablated in patients with long-standing persistent atrial fibrillation. So in this type of patient, edema created by the ablation may be a problem to completely choose the best device sites for the patient. But in an ideal situation, ablation of pulmonary vein, posterior wall, and closure during the same procedure, I think makes sense to me, will facilitate many patients, reduce the number of procedures. So it is something that we should look at in future. And I think that redo procedures can be done in patients that have a closure device. Now, the randomized trial have not reproduced. Well, they have not reproduced because, for example, the Cabana had to change the endpoint over the enrollment because they had to stop the trial prematurely because they couldn't enroll more patients. So they put composite endpoint between the ablation and the medication. I think there is no doubt that ablation is better than medication in maintaining sinus rhythm and follow-up. And we also know from East AFib and the East AFib trial that it does improve cardiovascular mortality and stroke, the maintenance of sinus rhythm. So I think we just have not done the right trial with the right statistical design, but the data there are clear. And sometimes, you don't need all the time a trial to justify a treatment. You don't need a randomized trial to jump off a plane with a parachute or without a parachute to know that the parachute is safer than no parachute. So I think that there is strong data that early ablation is the best way to maintain sinus rhythm and is probably the best way to reduce the stroke risk if patient remain in sinus rhythm.
All right, thank you.
There was a third part of your question, which was the Laos trial. Yes, the Laos trial give us a lot of confidence about the closure device. The closure device are a complicated topic because, at least in US, they are still not approved as a full alternative to anticoagulation. They are still, for patients that have contraindication to anticoagulation, but a full indication, say, I go to my patient, I say, do you want A or B, is not there. So I think we need to move forward to that in order to properly answer your question.
Yeah, thank you very much for your comment. I think, as you pointed out, it's still at least controversial at some points with regards to LA closure devices, and we need more data. Definitely need more data to demonstrate. So Option will be one very interesting trial coming up. From my colleagues and from the panelists, any other comments? No,
I mean, I think
no
the
more
main
comments.
thing is rhythm control does reduce the risk of stroke. We know that from East now, and it's a big groundswell change from our perspective up until, say, 2 years ago. And then on the heels of that, we know that ablation is the better means of rhythm control. So as Luigi said, controlling the rhythm is probably the first step. The second step is what else can we do on top of, the 80% reduction in stroke we see with anticoagulation. And Laos tells us that the appendage is a source, and managing the appendage does offer benefits to patients. I think Rodney had something to say.
Yeah, so Laos 3, there's really a lot to unpack with the data from that because most of the patients in the trial, they didn't specify how the appendage would be closed. So some of them were sutures, some of them were double sutures, some were clips, some were staples, things like that. So, and they left them on anticoagulants. So it's kind of interesting that even on anticoagulants, so presumably all of the patients in the trial, or almost all of the patients, were on anticoagulants regardless of whether the appendage was closed or not. The ones that had their appendage surgically closed or intended to be closed, depending on how they closed it, they did a lot better. So there's a lot to think about with that. I think it is a powerful statement for something that we've known a long time, is that if somebody is going to have a sternotomy and they're going to have their chest opened and you're staring at the appendage, why not close it? It's something that we've been strong advocates for a long time. And of course, that's tempered by the fact that if you close the appendage with a staple or a single suture, a lot of them end up not being closed, and you might actually make things worse. So there's a lot to unpack, and you don't just jump to one conclusion based on Laos 3, but it surprised me a little bit that they did so much better, even when both sides were on anticoagulants when the appendage was closed or intended to be closed. So there's a lot to think about.
Yeah.
But I think the alternative.
So thank you very much, gentlemen. I am afraid we are running out of time. And I think we had a wonderful session. We could spend hours to discuss even more. And I want again to thank you, Luigi, for your fantastic presentation, Jason and Rodney for your great insights. And ladies and gentlemen, that was the last session of today. But before we go, let's have a review of today's proceedings.